Good evening, everybody. Welcome to this EU IPFF webinar on comorbidities and progressive interstitial lung disease, or ILD. This is the second in a series of monthly webinars that we are holding leading up to the first European Pulmonary Fibrosis Patient Summit, which will be a virtual event in April of this year. My name is Steve Jones. I'm the president of EU IPFF, the European Pulmonary Fibrosis Federation, which comprises 21 patient organizations from 15 countries across Europe. I'm also the chair of the UK patient organization Action for Pulmonary Fibrosis. As many of you know, we plan to hold the European Pulmonary Fibrosis Summit in Poland in April 2020, but because of the COVID epidemic, we had to postpone, and we've decided now the best plan is to hold it virtually in April 2021. We were very disappointed to postpone because we had arranged a great program with lots of exciting speakers and lots of events for the Warsaw meeting. However, I'm pleased to say that we have one of those exciting speakers with us here tonight. It gives me great pleasure to introduce Professor Michael Kreuter, who is head of the ILD Expert Center in Heidelberg in Germany, and is one of the leading global researchers on interstitial lung disease. Michael is active in the European Respiratory Society and is soon to become the secretary of the ERS ILD Assembly, which brings together most of the doctors in Europe interested in research on ILD. Michael believes strongly in involving patients in healthcare and research, and he is and always was a great supporter of EU IPFF. Some of you may have seen Michael at the 2019 ERS Congress in Madrid, in conversation on stage in front of many hundreds of people with my colleague Klaus Geisler, one of his IPF patients, discussing the PF, the pulmonary fibrosis patient journey and how doctors and patients can work most effectively together. It's really not to be missed. I'm sure it's somewhere on YouTube if you look for it. You may remember last time that we joked a little bit with Gisli Jenkins about his cycling prowess and how much money he was raising for Action for Pulmonary Fibrosis. Well, I think in Michael, Gisli has found his match in more ways than one. Michael is an accomplished trumpet player and frequently gives concerts in support of patient organizations. I was going to ask you to bring your trumpet tonight, Michael, but I thought maybe we probably wouldn't have enough time. But maybe on another occasion. Yeah. Anyway, Michael is going to split his talk tonight into two parts. He'll first talk for 15 minutes on the importance of comorbidities, and that will be across all forms of pulmonary fibrosis, including IPF. We'll follow that with 10 minutes of Q&A. He'll then talk for 15 more minutes about fibrotic ILD, or what we might call non-IPF progressive pulmonary fibrosis. So we're talking about the types of disease like chronic hypersensitivity, pneumonitis, or farmer's lung type diseases, about connective tissue and autoimmune diseases. We'll follow that with 20 minutes of Q&A, and we aim to finish tonight by 2015 Central European time or 1915 UK time. Could I have the next slide, Michael? Could I please ask you to submit any questions you'd like to ask using the Q&A button at the bottom of your screen? I think many of you will know this from the last time we did it. Please use the Q&A function and not the chat function. When you submit your questions, be really glad if you could write complete questions and make them as succinct as possible, because if you start entering in comments or random thoughts, it's going to clog up the system and make it a bit more difficult to get to the essence of the matter. If there are any other questions that we don't have time for tonight, Michael has kindly offered to provide written responses afterwards, and these will be available on our website. I'm really pleased tonight that in addition to all of us here listening to the webinar in English, the Greek patient organization, which is very active, has a translator on with us. You can see her possibly on your screen as Mirka Kapi. She will be doing simultaneous translation into Greek for people in Greece, which is great. So welcome very much to everybody from Athens and other parts of Greece. As I say, the webinar will be recorded. It will be made available online on the EU IPFF website in English, and within 2 weeks in 5 other European languages with subtitles. So I think that's about it for now. Without further ado, it gives me great pleasure to welcome Professor Michael Kreuter and invite him to talk to us about the importance of comorbidities and progressive interstitial lung disease. Thanks, Michael. Over to you.
Dear ladies and gentlemen, first of all, it's a great pleasure, well, not seeing but speaking to you at least tonight, and it was a great honor being invited to be your guest, Steve, tonight, and especially thank you very much for a very kind introduction. Those of you who do not believe that I play the trumpet, well, I could open my door and then you could hear my eldest son practicing his trombone currently, and if I would not be with you tonight, I would practice together with him. So yes, it's in the family. But if you're a little bit more interested in what are the effects of, let's say, brass instruments on lung diseases, well, you could either follow one of my talks about that very interesting topics, or you could go to on the website of the Thorax Clinic. That is the place where I'm working, because about a year ago we had our last charity concert, and Klaus and others were also guests there, and we had a marvelous concert from a British composer, which was great, together with a students choir here in Germany. So I think music is very fantastic and fascinating. However, what is also fascinating, and I think especially for you as patients, very important to understand, is the role of so-called comorbidities, and then a little bit later on what progressive fibrosis in interstitial lung disease means. What you can see here is my and what you can see here is the importance and the question what comorbidities are. So first of all, let me explain to you what a comorbid condition is. That means those of you, for instance, who are suffering from IPF, that means the question, is there any other comorbid condition which affects the patient? And as you can see here, these data come from the German registry, the so-called German Insights IPFF registry. And at that time, we had about 700 patients, and we asked those patients, what other kinds of diseases are you suffering from? And what you can see here is that out of about 600 patients, you see here that the huge majority of patients have whatever kind of different other diseases, and that there is a minority of patients who do not suffer from any kind of comorbid conditions, less than 15%. Which means comorbid conditions, speaking again, others than interstitial lung disease, are very prominent in our patients. However, there is one important consideration which you must not forget, and that is this, that IPF is a disease of the aging population. And you can see here Marlon Brando, one of the most prominent patients with IPF when he was old and when he was suffering from IPF at that time. And we do know, and this is data coming from COPD, however, this is translatable also to IPF. We do know that the older a human being gets, the more disorders are affecting him or her. What you can see here, the dotted lines mean this is the typical age when we detect IPF and our COPD. And you can see here, the older a patient gets, the more other conditions, comorbid conditions, these patients are suffering from. And a very good example of this is this one here, is our arterial hypertension. On the left side here, you can see a meta-analysis from 2016 being published by Ganesh Raghu. What he did here is he acquired all available information on how frequent arterial hypertension in patients with IPF is. And you can see here, this is up to about 70%. And if you comprise all these data together, it's something between 50 to 70%. And this is, looking here at data coming from Germany, very typical for the people who are affected by IPF. This is an elderly population, something between 50 and 80 years old. And you can see here these data come from Germany, that arterial hypertension in around 60 years old patients is about 60%, and the 80 years old patients about 80%. Perhaps there's some cofactors, for instance, people suffering from chronic lung disorders have exercise, which increases blood pressure. Sometimes they're using steroids, increasing blood pressure. Smokers or ex-smokers and also so-called sleep apnea increase arterial hypertension. However, there's a little bit more in the relationship between aging and lung diseases, aging and comorbid conditions in IPF, and that is emphysema, smoker's lung, and IPF. And you can see here that is a typical finding in the patient suffering from a fibrotic lung disease, and you can see fibrosis here or here, and this here, these are the remnants of smoking. This is what we call emphysema. And we do know that there is some genetic changes, which we call telomeres, and the older you get, the more shortening of these telomeres you have. And we do know that in diseases where we have a earlier aging than in other patients or people, we do know that this telomere shortening is associated with some cofactors. And a typical cofactor is smoking. And smoking may affect so-called precursor cells, which means on one hand so-called mesenchymal cells, that is cells we find in the lung parenchyma, and then that may lead to emphysema, that is this one here, that is the smoker's lung, or it can also affect epithelial cells and then leading to fibrosis. So there is one link with aging and comorbid conditions here, emphysema. However, there's a little bit more than aging. And a little bit more than aging is the question, is there some form of a comorbid condition of an other disease which may lead or even aggravate our lung fibrosis? And that might be diabetes. From a German analysis, we learned that in patients who suffer from diabetes, the more diabetic they are, the more dyspneic they are, outside of having cardiac disease. And also, this data here, it shows that if you look at a patient with diabetes and you perform a lung function, then you see that these people may have a restrictive lung disease, which means if you perform lung function, the lung volume curve is shrinking. That is what you also see in patients with lung fibrosis. And there is some older data you can see here from Hunt and colleagues and Enomoto and colleagues. That is data coming from Japan here, looking at risk factors for the development of IPF. And what this Japanese group has found out is that diabetes mellitus is associated with the development of IPF, which means, and we think that hyperglycemia means more blood sugar, may affect the clearance of bacteria in the lung and perhaps also may induce fibrotic scarring in the lung, so that we may have a link between a comorbid condition, diabetes, and the development of IPF or other fibrotic lung diseases. However, there's a little bit more. And this sounds very, very simple, but it is, I think, very complex. That is, how much does IPF or other fibrotic lung diseases affect quality of life? And if you suffer from more than that condition, does this even aggravate your loss of quality of life? And that is something we looked into again in the German INSATS IPF registry. We compared patients without any comorbid conditions outside of IPF to, for instance, patients having more or equal to 4 comorbid conditions. And what you can see here is, so that is quality of life as measured with the so-called St. George's Respiratory Questionnaire. And the higher the bar, the less the quality of life is. And if you see here an increase, that means that there is a worse quality of life. And if you see here without any and with equal to or more than 4 comorbid conditions, you can see here this heavily affects quality of life. But this is not the only important finding. The other very important finding is this one here. That is, if you have the same IPF patient without any comorbid condition this is this one here, and you compare that IPF patient to a patient who has several comorbid conditions, that also affects outcomes. And you can see here, having no comorbid conditions and more than 4 comorbid conditions, there is a separation of these lines, and this is survival lines, which means we have to look at comorbid conditions with regards to quality of life, but also with regards to outcomes. And there's one very important comorbid condition, and that is lung cancer. And there's several observations coming from Asia, especially from Japan, but also from Europe. And you can see here European data, which shows us that over the time, a patient with IPF, and this is a lot of smokers, ex-smokers, ex-male smokers, and they develop lung cancer, but also in patients who never smoked. And we think that there's a link between the development of lung cancer and IPF, and especially once these two diseases come together, then it is very complicated because it affects your survival and it affects your quality of life, and especially the treatments we are choosing may affect the treatments we are choosing against lung cancer may also affect IPF because we may induce some worsening. And this worsening is, for instance, called acute exacerbation. So if we perform surgery on lung cancer in an IPF patient, then perhaps we may see an acute exacerbation. And that is one of the most detrimental linkages we can see in comorbid conditions. However, there's other diseases. And one of these other diseases is so-called reflux disease, meaning of heartburn. And there is some discussion about that if you have some so-called microaspirations of gastric or you're swallowing in gastric compounds which are acidic, that might perhaps aggravate or even induce inflammation in the lung, that may lead to the development or aggravation of lung. However, what was observed is a little bit controversy. That is what you can see here. So you can see here that is again survival curves. That is the absence of the diagnosis of symptomatic reflux disease, and that is the presence in one. And here in another cohort, you can see here very similarly that when patients have reflux disease, they have a better outcome. So why is that? And that is a very long-standing discussion which is still ongoing, and that is about the medical treatment with called anti-acid therapy, which you may know with the name of proton pump inhibitors. And there was a post-hoc analysis of data coming from the IPFNet in the United States, and they looked into their trials and looked into the so-called placebo cohorts, meaning the patients didn't receive an intervention, and they compared patients who received PPI and patients not receiving PPI. And you can see here that there's a little bit more stabilization with those having compared to those not having PPI. However, there's other data coming from controlled clinical trials. Again, a post-hoc analysis, meaning that was not a clinical trial comparing PPI to no PPI. That was a trial, for instance, in this one here, comparing pirfenidone to placebo. And we looked here into the placebo arm and looked to those patients who have anti-acid therapy, PPIs, whereas not having, we don't see any outcomes. And that is a matter of debate. So we do know that reflux disease has some link with the development of IPF. We see perhaps a better outcome. It may be associated with a therapy of reflux disease, but currently we don't know whether this is true, yes or no. And what we may need for this is a clinical trial investigating the use of proton pump inhibitors. There's other diseases, and this is very frequent disease that is so-called coronary artery disease. Well, what we do know is that our patients with COPD are more than 90% smokers. And we do know that our patients with COPD, with smoker's lung, that these patients have a very high risk of developing significant coronary artery disease. Stephen Nathan from the US compared patients with IPF on one hand and COPD on the other hand, and looked into who may develop more coronary artery disease, and everybody would have thought, because the people who are smokers or ex-smokers in COPD is very high. So we thought that it is more frequent in COPD. However, what he showed was that it is even higher in IPF. And there was an extremely lower frequency of smokers or ex-smokers. And what he also showed is this one here, that our coronary artery disease is also affecting quality of life and outcomes in patients with IPF, meaning that coronary artery disease is also a very important comorbid condition in patients with IPF. And again, looking into drugs, which is, I think, very important, there was an observation that if you look into patients who have a very heavy smoking history, that is more or less something we call a registry called COPD gene. And the colleagues here analyzed for different forms of drugs and whether these drugs affect the lung. And what they found out is they didn't look at COPD in this analysis, they looked at the development of fibrosis in the lungs. What they found out is that with one drug you are using very frequently to treat at least some outcomes in coronary artery disease, the so-called statins, they described that once you're taking statins, then perhaps you may develop lung fibrosis. However, another investigation looked again into placebo arms of clinical prospective trials and found out, that is this data here, that at least with statins, there's a trend to better survival and to less problems associated with IPF. So on one hand, perhaps drugs may induce or aggravate, or on the other hand, may also have a positive outcome or effects on IPF. And one of the very typical exemplification is statins. And with regards to comorbid conditions, and this was also a very short view on what comorbid conditions may mean in IPF, is this summary here. That is what we call a comorbidome. What does this mean? You see here several dots. And the bigger a dot, the more frequent this comorbid condition is. And you see here this dotted line, and comorbid conditions which are within these lines are associated with death in a patient with IPF. So coming back, for instance, here to here, looking at the outcome of a patient with IPF to lung cancer, you see here that is the closest relationship, as shown a little bit earlier. But what I would like to highlight is more this one here. If you compare a patient, and that is data coming from a German healthcare institute, and we looked into data of a German healthcare institution, and we compared patients, for instance, suffering from COPD, the patients in patients who are not treated to patients who are treated, and you can see here that perhaps patients who have COPD and are treated for their disease COPD compared to those not treated for COPD, that those treated for the comorbid condition may have a better outcome. And that brings me to the last point with regards to comorbid conditions. And that is a slide we brought up a couple of years ago together with Weisenbeck on how to care for patients with interstitial lung disease, the so-called ABCDE. And the ABCDE, the C here, also stands for comorbid conditions, looking at very important comorbid conditions. One, for instance, I didn't speak about is obstructive sleep apnea, where we do know that treatment of obstructive sleep apnea may affect your outcome positively in IPF with regards to outcome, but also with regards to quality of life. So looking at comorbid conditions and treating these comorbid conditions as one would do in a non-IPF affected patient, this is a very important points of care in ILD. And with this, I think we should start discussing this first topic before we go to another very important but very different topic, speaking about comorbid conditions. And if you are having questions, then please put these in.
Great, I'll take over, Michael. That's great. Thank you very much, Michael. That was a great start to the evening. And we've got a couple of questions already come in. One is a couple of the Greek participants have noticed that some of their older colleagues with IPF have recently been vaccinated for COVID, and some of them have since died, possibly some doctors claiming it was the result of comorbidities associated with vaccination and everything. Is that something? I've not heard of that. Is that at all something that is of concern?
Well, this is a very important but currently unsolvable question. So I think the most important observation which has been made in this regard comes from Norway. And there was some vaccination in elderly people's home, and some of these people died after vaccination. And many of these patients were very old and very comorbid. Yes, vaccination may be associated with side effects, but I have seen several patients with COVID. COVID is much more worse. So perhaps, yes, there may be side effects, but if comorbid conditions really affect side effects or even lead to let's say, morbidity or mortality after the vaccination, IPF or comorbid conditions is unsolved. But to be honest, I don't think so. And especially a corona infection in people like you, I think is much more dangerous than the vaccination.
Great, thanks. And that's a really important point, that balance of risks, isn't it? A point is one person didn't quite get the point you made about the impact of proton pump inhibitor treatment on exacerbation and pulmonary fibrosis, and asked if you could clarify that.
Okay, so this is a little bit complicated. I know it is also complicated. Yeah, I try to clarify that simply. So, comorbid conditions are an effect on patients with IPF. What we have noticed is that patients with reflux disease, and reflux disease means you have symptoms, but these patients have a better outcome. So there are several thoughts about this. One is, if you have reflux that leads to cough, and cough, you go to your GP, and that GP sends you to the pulmonologist, and then you have a workup. And perhaps if you have reflux and you're coughing and you're sent earlier to the pulmonologist, then perhaps IPF might be diagnosed earlier, which means that may explain why patients who have reflux disease symptoms associated with reflux have a better outcome. I hope that is clear. Another possibility is that if we have reflux, and reflux may induce or accurate IPF, meaning you have gastric compounds and these are acidic, and you have so-called microaspirations, meaning while you're sleeping, you're lying like this, and then you have a little bit of amount of, let's say, a milliliter or even less of gastric compounds. You're swallowing and then aspirating into your lung. Mm-hmm. And that may lead to some form of an inflammation because this is acid. Just remember, if you put acid on your skin, what that makes, it makes an inflammation, and that same may happen in your lung. So if you consider to treat a acidic compound, you may see less inflammation in the lung, which means that was more or less the initial idea of using PPI or investigating proton pump inhibitors because they decrease the acidic compound in the gastric content, which may then perhaps be a treatment against IPF. And there is several investigations. The first one coming from Joycelyn Lee and from Ganesh Raghu, looking into patients with IPF who were part of a clinical trial. And in the placebo arm, meaning this as the patients who don't get the intervention. These patients, they were analyzed for they are having proton pump inhibitors versus not having, but not for the indication of IPF, but for the indication of whatever. For instance, having a lot of drugs, having steroids, or having reflux disease. And what they found out is that patients who had proton pump inhibitors had a better survival than the others, or had less lung function decrease. However, there's other data coming from postdoc analyses of the pirfenidone trials, and later on also from others, where we demonstrated that these effects could not be shown again. So PPI might be a treatment because we may decrease the acidic compound of microaspiration, but perhaps it is not, and that is something which is currently unclear. So hopefully that clarifies.
Great. No, thank you for that. And there is a study just started at the University of East Anglia across 40 hospitals in the UK, looking again at the question of whether taking a protein pump inhibitor will actually slow down progression of IPF. So there's, I mean, we don't have we don't have a definitive answer at the moment, do we? Really? Yeah. Okay.
No, we don't, and that is why we need these kind of trials.
Great. Thanks, Michael. A question from on pirfenidone. And the worry about vaccination again. I think inevitably there's going to be a lot of questions on vaccination
Sure.
tonight. And the question, if you've shown a reaction to pirfenidone in the past, I heard of a friend of mine today who did, would they inform the doctor before vaccination?
So reaction against pirfenidone does mean what? A allergic reaction?
Well, one colleague I know of did have an allergic reaction.
Okay.
And I think he thinks they probably decided not to give him the Pfizer vaccine.
Okay.
But what your view would be on that?
Well, what we do know is that once you're allergic in general, then you may have more allergic reactions against whatever drug. However, we do know that there's a difference between different drugs. So, for instance, pirfenidone is a drug where there's at least a kind of a increased risk of a allergic drug reaction. However, I think that this, and it's not easy to answer, I think this is overestimating the allergic drug reaction against the vaccination. So there might be some risk. So perhaps you may be a little bit less worried if you wait for another drug. However, the allergic drug reaction against the Pfizer-BioNTech vaccination, I think, is quite low. And again, well, I got my 2 shots already because we are very exposed in our hospital. And yes, there are side effects, but to be honest, I've seen many COVID patients and also patients with IPF or other fibrotic lung diseases and COVID. And to be honest, I would not dare not to get any vaccination. I would for the vaccination because you're observed 30 minutes after that, whether you develop an allergic reaction, yes or no. And even if you do, then you will not receive the second vaccination. So I would still go for vaccination, even if I have seen allergic drug reaction against pirfenidone.
That's very helpful. Thank you, Michael. And another question about patients saying that they're surprised to see osteoporosis mentioned as a comorbidity, and they're asking if this condition can influence treatment in IPF. What's the relationship with IPF? And
this is a very good point. So we don't have many data on that. We published some data as an abstract, meaning we presented data at a scientific conference at the ERS conference 2 years ago. So what we do see is that in patients with interstitial lung disease in general, they have more osteoporosis than patients without. And one of the reasons might be the association between former steroid treatment, because we do know that steroids may affect osteoporosis. But there's a little bit more than that, perhaps. So because we are seeing this also in IPF, a disease which at least since about 8 years is not treated with steroids anymore. And it is currently unclear why, but we think there is a kind of a relationship between different diseases like diabetes and so on, where you have a lot of hormones affected, and also osteoporosis is a kind of a metabolic disease. So perhaps there's some linkage. What that means is still unclear. And yes, what we should do is we should screen our patients for osteoporosis. However, most of you receive at least at their first diagnosis and perhaps then annually or every second year or whatever a thoracic CT, and then you can look at the spine and then you can see whether there's osteoporosis present, yes or no.
Great. Okay. One other question before we move on, and there are 1 or 2 others that we'll keep for later as well. You mentioned that diabetes is associated with IPF, and you hypothesized about increasing blood sugar and the impact that has. It's interesting that that's also associated with COVID-19 and the process of damage to the lungs in COVID. Are these 2 things related?
This is a very good question. This is an open question. This is currently investigated. I think there might be a linkage because once you have diabetes, then your immune system is not working properly. which means your local immune system in the lungs, which may then aggravate or induce pulmonary fibrosis. And on the other hand, perhaps may make your lung more prone to develop fibrosis once you're affected by COVID. So perhaps, yes, there is a link, but still unclear why.
Great. Okay. Well, let's move on then, Michael, to the second part of your talk, and then I'll save the other couple of questions here until later. If I could just ask somebody, Michael Lyon sent a question in on comorbidities treatment cancer. Michael, would you mind sending that question again clearly, because I don't quite understand what it is you're asking. Great. So over to you, Michael. Thank you.
So another important point I would like to with you, and I think that would be perhaps a future talk for a whole evening, is what we call progressive fibrosis in fibrosing interstitial lung disease. So what this means, I hope to clarify within the next 15 minutes. That comes from an observation like this one here. So that is looking at a patient with IPF, and this here is the onset of symptoms in a patient with IPF, and you do know that we have a very heterogeneous course of disease, but we do know that in these patients we have a constant progression of their fibrotic scarring. And we do know that IPF is associated with a detrimental outcome, but there's other diseases where we have very comparable data. And these diseases, fibrotic lung diseases, are, for instance, systemic sclerosis affecting the lungs, rheumatoid arthritis affecting the lungs, or, for instance, hypersensitivity pneumonitis. So let me give you one example. That is systemic sclerosis. That is not a disease limited to the lungs. It's a disease where almost every organ can have a kind of a fibrosis. And what we have seen in the 70s is that the patients were mainly compromised by renal failure. And once the rheumatologist detected what is the underlying pathophysiology behind that, they avoided, for instance, drugs like steroids or used ACE inhibitors. And once they were able to identify and treat the severe complication, then other complications, organ complications, popped up. For instance, this one here, that is pulmonary hypertension. However, then currently we have, for patients affected by systemic sclerosis, we have early diagnosis and early treatment with drugs. And once this was achieved, then we have this one here, and that is what patients with systemic affecting, that is interstitial lung disease, that is fibrotic scarring of the lung. And we do know that it is very clearly associated with a progression of systemic sclerosis in general, especially progression of fibrotic scarring in the lung, and also with outcomes. Very comparable, another disease, rheumatoid arthritis, then Danish data showing us that once you're a patient with rheumatoid arthritis and you are not having a pulmonary complication, mainly ILD, compared to patients with rheumatoid arthritis where ILD is present, then you can see here that mortality rates are almost doubled once you're affected by ILD. And the question is, and that question came up about 10 years ago, if you're a patient with a lung fibrosis, may fibrosis behave very similar? And what you can see here, that is what we call the so-called UIP pattern, and some of you may have heard that. UIP pattern means scarring of the lung, and you can see typical features, for instance, these so-called honeycomb changes, which is a prominent feature of UIP pattern. But UIP pattern in general is not a disease, it is a pattern. And you can find it in IPF, but you can also find it, for instance, in rheumatoid arthritis ILD. You can find it in asbestos-associated and related interstitial lung disease, or, for instance, in fibrosing hypersensitivity pneumonitis. And the question is whether this may lead to what you have seen here, to the detrimental outcomes associated with lung fibrosis in non-IPF but other ILD patients. And in order to understand that better, I brought a patient of mine to you. So that patient was suffering from some dyspnea since 6 months. However, he was not affected by cough. The patient had no exposures. However, looking at his comorbid conditions, he was diagnosed with rheumatoid arthritis a year ago, and he has received some treatment with methotrexate and steroids. And what you can see here is the so-called baseline lung function. And I think most of you know what vital capacity is. It more or less shows you how large your lung is, how much air can go into your lung. And also diffusion capacity was significantly impaired. That means how much oxygen your lung can take up. And what you can see here is his CT. You see here, this is the heart, and this here, for instance, is bone. This is the spine. And everything which is black is air. And this black here is air in the left and here in the right lung. What you can see here is these things here, this one here, these white things within the black holes. That is fibrosis, that is scarring in the lung. So that patient, because he had fibrosis and that patient had rheumatoid arthritis, is by definition a rheumatoid arthritis associated interstitial lung disease. And at that time, we initiated some form of immunomodulatory drug treatment. And that patient was followed up after 12 months. And you can see here lung function at baseline, lung function after a year, diffusion capacity at baseline, diffusion capacity after a year, that is stable. However, that patient then developed some more here. And we performed a new lung function and a new HRCT. And what you can see here, initial lung function and follow-up lung function, the patient lost 5% of vital capacity. And I think what you can especially see here is this one here. So that is the initial CT, that is the follow-up CT. And you see here, these white lines compared to these lines here. That is an increase of fibrotic scarring on lung CT. And that is what we call, and the disease behavior is very similar to IPF, a progressive pulmonary fibrosis, for instance, here in a patient with rheumatoid arthritis. And we can find this phenotype or this subtype in several ILD types. And these subtypes will be more or less found in all patients as IPF. You also can find it in so-called idiopathic NSIP, also in hypersensitivity pneumonitis, or in systemic diseases, for instance, in rheumatoid arthritis or systemic sclerosis, ILD, and also in so-called pneumoconiosis and asbestos-associated interstitial lung disease. When do we speak about a progressive fibrosis? Well, this is currently under debate and an international guideline, perhaps in future, but we came up with at least our suggested definition currently, and why we came up with this, we'll speak about this a little bit later. So we look at the development of lung function over 2 years, meaning a decline in lung function, or the combination of a decline in lung function and decline in diffusion capacity, or the combination with an increased fibrosis on HRCT, or in the combination with progressive symptoms, or the combination of having more symptoms and having more fibrotic scarring on HRCT. So that is where we are speaking currently about a progressive fibrotic phenotype in patients with ILD outside of IPF. So what do we know about these patients? Not that much currently. However, this is data very recently published by Professor Vincent Courtin's group. And he looked into several factors, and what I would like to highlight is this one here. That means that if you're a patient with this PF-ILD phenotype, then you have a higher chance of having a more severe course of the disease if you, for instance, have a so-called unclassifiable or a fibrotic hypersensitivity pneumonitis, or if you have a lower lung function at baseline, have more decline of lung function over the time, and if you're older. And the main question is, how can we stop that fibrotic scarring? And this here is data from a survey we've performed about 2 years ago. And we asked physicians, pulmonologists, and also here rheumatologists, how do you treat these patients who have a progression despite other treatments? And I brought you that slide because what you can see here is there's a lot of colors. And that means once you see a lot of colors that nobody really has a clue what to do. So we're starting here, for instance, with connective tissue disease associated ILD. And once you are diagnosed with a connective tissue disease associated ILD, you ask together with your patient the question, is this clinically significant? And then you initiate immune suppressive therapy. And that is what you can see here. But if you have an aggravation of fibrosis, then you have to consider this one here, because we do know a disease where we have a progressive scarring, a progressive fibrotic phenotype, and that is IPF. And in this one here, we have a treatment we call anti-fibrotic therapy. However, again, immune suppression was only available here. And Ariel Fisher, who was is a rheumatologist, together with Ron Duba, who was a pulmonologist at the Royal Providence and in Denver some years ago, they asked themselves the question, if you have a lung fibrosis, even in another disease as IPF, and that disease behaves like IPF, shouldn't we consider to treat that as an IPF? And that is what we call a clinical trial in PF-ILD. And there is currently 3 trials published, and we'll show you results of 2 of them. The first one is the so-called INBUILD trial, and they investigated nintedanib, a drug patients with IPF amongst you may know, over a year, and giving them either the drug or a placebo, and it will show which kinds of diseases were investigated. And there was another study, the so-called RELIEF trial, which was performed in Germany by the German Center for Lung Research, again over about a year. However, we have to prematurely stop that because of several problems associated with that. And then finally, there was another trial looking only at unclassifiable patients over half a year. And the patients who were included into these trials were, and you can see here, these dots is the INBUILD, and this blue dots is the German RELIEF study, and the yellow dots is the UILD study. So in the unclassifiable study, it was more or less only unclassifiable. In the INBUILD study, that included these patients, but also the patients with NSP, systemic disease-associated ILD, hypersensitivity pneumonitis, and very much comparable with the German RELIEF study. So very broad in INBUILD and a little bit less broad, but still very broad in the German RELIEF study. Now that here is the outcomes we found in the INBUILD study. So I would like to explain these data to you. So that is patients in the overall population, meaning all the different diseases which have been included with hypersensitivity pneumonitis or systemic disease associated ILD and so on. You can see here over a year the course of lung function in those who received nintedanib compared to receiving placebo. And what you can see here is that there was a more severe lung functional decline in the placebo cohort compared to patients on nintedanib. And this is very much in line with the data we have seen in the so-called INBUILD study, that were the studies leading to the approval of nintedanib in IPF. So a patient with placebo lost about 200 mils, and you can see here this is very consistent with this study. And in the nintedanib arm, it was in the IPF study about 100 mils, and you can see here this is very much consistent with about 80 to 100 mils. So you see here there's less decline in the patients who receive the antifibrotic drug. And also we have seen this one here, and I think this is very important. One very important complication in patients with fibrotic lung disease is so-called acute exacerbation, which means this is a very rapid onset of an aggravation of the disease. And we know from IPF that nintedanib may reduce the number, or at least the time to the first acute exacerbation, and that is also something they showed here in the INBUILD study in nintedanib patients compared to placebo. Here in the nintedanib patients, we had a positive effect on the first time of acute exacerbation. And this is very much consistent with a German relief study that was a little bit complicated, so I will try to make it a little bit more easier. Just look at these data. So this is over 48 weeks with those patients who have been included, those patients receiving pirfenidone compared to patients with placebo. And what you can see here, there is a clear difference comparable to here. For those patients with pirfenidone had less functional decline compared to those receiving placebo, which means that antifibrotic treatment in a patient who has not IPF but whose pulmonary fibrosis behaves like IPF, an antifibrotic therapy might be a good choice. However, there's a lot of caveats which I would like to discuss with you at the final end. So this year is, ladies and gentlemen, I have seen over the last years in my ILD centers. And all these patients had very similar symptoms. They had an acceleration of our dyspnea on exertion. So this lady here, and you can see here where the initial lung functional values had, after 1.5 years, a significant decline of 10% with regards to vital capacity. And then we looked at the computed tomography at the HRCT, and I think you all know are very professional in reading CTs. You can see here more fibrotic scarring after 1.5 years compared to the initial CT. But we have to be very, that gentleman here had an initial vital capacity of 61%. Then the gentleman developed more symptoms, and you see here, after 2 years, he had a significant decline in lung function from 61% to 50%. So he lost even more than 10%. However, that was a patient looking at the CT where we didn't see a acceleration of fibrotic scarring, but we have seen more ground glass opacities. And the patient was suffering from a fibrotic hypersensitivity pneumonitis, and the alveolytic component, the more inflammatory component, was worsening. Because that patient was a bird breeder and he had again contact to birds, and that led to the development of the more or less acute inflammation, which means we have to look at, for instance, what are other factors causing more dyspnea? Is it the fibrotic scarring? Then yes, it is antifibrotic therapy. Or is it other factors, like in that patient? Again, he was exposed to what was the initiator of his lung fibrosis, of his interstitial lung disease, and then we took off the birds again, and then the patient improved. And the last patient was a lady suffering from systemic sclerosis. And that patient also had an acceleration of symptoms. And even looking at lung function values, you see here there was a significant decline. However, once we performed an HRCT, and here you see that is, for instance, the left lung at the very basal part, you can see here in the very basal parts that is almost equal. There is no acceleration. And where does this acceleration come from? In a patient with systemic sclerosis, we are finding a very high rate of pulmonary hypertension, and that was prominent in that patient. So that patient had not a disease which could be treated with an antifibrotic drug, but that patient then received drugs against pulmonary arterial hypertension. So progressive fibrosing ILD is not a disease. It's a phenotype, it's a subtype in different fibrotic ILDs. And there's a couple of open questions. We do know that antifibrotic therapy helps. However, treatment algorithms have still to be established, and especially we need an internationally accepted definition for this. And with this, I hope that I have clarified a little bit more what PF-ILD means, and if and when antifibrotic therapy might be helpful. With this, thank you very much. Looking forward to the next round of questions. Steve.
Great. Thank you very much, Michael. Going on, we have a number of interesting questions coming up. One, just to start with, so just to get for everybody to understand what phenotype means, I guess it means, is it the way in which a disease behaves? So these different diseases, RA, ILD, behave in a certain way, and are all of them experienced by patients in a very similar way? They all involve increasing breathlessness. They all may involve cough. fatigue, and eventually dependent on oxygen. Yeah, the pathway is similar, yeah? Would that be a fair definition of phenotype?
So with a phenotype, we mean, but still we are waiting for a better definition than phenotype, or you can also say subtype. So let's, for instance, go back again to rheumatoid arthritis ILD. So if you look at 100 people with rheumatoid arthritis ILD, and they all have fibrotic scarring, and perhaps they may look with a CT very similar to IPF. From these 100 people, about 40 have a progressive fibrotic scarring, that is the PF-ILD phenotype, and 60 of these people never have an aggravation of their fibrosis, which means those 40 people have the subtype of a progressive fibrosis or phenotype of progressive fibrosis. The difference are not clear yet. We are investigating factors for that, and we think that there may be some genetic background on this.
Okay, that's very helpful. And there is a study coming out, I think, in a couple months' time in the European Respiratory Journal, which some people in the UK have done, looking at the number of people who have a fibrotic ILD defined in the way you did with those the inbuilt criteria. They reckon that for every 10 IPF patients, possibly 4 to 5 patients have other kinds of progressive fibrosing ILD, the RA-ILD and things. So it's often easy. I mean, a lot of us on the call, I imagine, have IPF, but we have brothers and sisters who tend to have these other diseases. So for every 10 of us with IPF, there's 4 or 5 with the other ones. And the difference is, whereas IPF tends to be, as I understand it, largely a disease of older white men, the population of people with the other diseases tends to be younger. They get diagnosed, I believe, when they're 40 to 60 years old. And you get a greater ethnic and other diversity. And indeed, I think women are slightly more than men in that group. So, there's these interesting differences, and yet we are all behaving, our disease is behaving in a similar way.
Yes, correct. So this is, I think, a very nice summary of the main differences. So first we started to learn about IPF, what it means, who is being affected, and now we are learning that diseases who may have a IPF similar course of disease, maybe for instance systemic sclerosis, might be women, might be young people. So even there it is extremely important to recognize these people and then to treat these people and to stop the fibrotic scarring.
Great. There's an interesting question come from one gentleman here. Did the non-IPF patients in the inbuilt trial continue to receive their other medications?
Thank you very much. So just to avoid confusion, I didn't speak about this, but I think this is very important. So some drugs were forbidden, other drugs were possible, and there's an analysis of this, which I think is currently under review, means it is submitted to a journal, and their reviewers, other colleagues, are looking at these data. So we not exactly know what are the outcomes with those who are having other immunomodulatory drugs or only antifibrotic drugs. But yes, some immunomodulatory drugs were allowed. Why? So again, looking at rheumatoid arthritis or systemic sclerosis associated ILD, that is inflammatory systemic diseases, and there might be other, besides the lung, other organ complications, for instance, rheumatoid arthritis, the joints. So you perhaps need methotrexate or other drugs so that you don't have problems there. So that is why it was allowed.
Yeah, that does. I mean, there was another question asked about whether there's any truth in the connection between long-term use of methotrexate causing lung scarring.
Thank you very much. A very important point. So when I was at medical school, I learned that there's a couple of drugs which may induce lung diseases. And the one everybody recognizes is methotrexate. So a very long time, we as pulmonologists thought that methotrexate is a kind of is a kind of a devil to the lungs. Now we are learning that methotrexate might even be a good a good drug if you're suffering from a lung disease, especially if you're suffering from lung fibrosis. And when we are now having more and more data showing that methotrexate might also be a treatment against fibrotic lung disease, or at least that the rate of problems associated with interstitial lung diseases due to methotrexate is extremely less than the problem with rheumatoid arthritis ILD, and that perhaps methotrexate can help there.
Great. There's another question which I'll just summarize. I mean, we're moving a little bit back into the comorbidities and mixing up the two parts of your talk. Somebody asks from Greece about the terrible, the unstoppable cough that one gets with IPF well, some people, when I had IPF before my transplant, I had it throughout my 8 years, a very bad cough, but it becomes particularly bad in the final few years. The suggestion is, what medicines are available that would help to soothe that? Now, I know we don't have good ones or specific ones, but what's your view on that?
Well, a couple of answers to that. So first of all, you have to investigate where the cough comes from. Is it coming from the fibrosis, or is it coming from other factors? We have discussed one factor already, that is reflux disease. So that is why many of us do a trial on PPI to decrease cough, and that works in about a third of our patients. Second is, there's other drugs like so-called ACE inhibitors, which are used to treat arterial hypertension or coronary artery disease. And we do know that that also may induce cough. So if you have an ACE inhibitor and you have cough, perhaps speak to your pulmonologist or a GP that you at least try to stop it. And there's a couple of other explanations. And then, which is more prominent in patients with fibrotic lung disease, you have cough associated with your lung fibrosis. And you can do a couple of things. So one of kind of effective treatments is low-dose steroids, meaning about 5 milligrams or so. That might be helpful in a couple of patients. Then we have the typical cough suppressants, which at least helps in some patients. And then what we have seen, and there's a little bit of literature on that, for instance, Marlies Weisenbeck published that on pirfenidone. So what she did was a small trial looking on the effects of pirfenidone on cough in IPF, and she has seen that there is a meaningful difference in those taking pirfenidone because it decreases cough. And moreover, there's a couple of new clinical trials more or less going to start very soon, and one has just been finalized. And that try new compounds or old compounds, however, in a new formulation have been used to treat cough in IPF or other fibrotic lung diseases. So there is not there much, but the drug choices are increasing. Perhaps the last word on that. So many have phlegm. So they have sputum, they have mucus. So there, for instance, inhalation with sodium chloride might be helpful.
Yeah. And there are other drugs like mucoids, carbocysteine and such. That would help.
To be honest, I'm not a very big fan of that. Or to be honest, I have seen vice versa, that these patients have more mucus and that these patients have an acceleration of cough. So at least in my patients, I'm not recommending these kinds of drugs.
Great, thank you. And to what extent do you think the IPF cough is actually a sort of neuropathological cough? It's caused by stresses on the nerves, maybe because of the fibrosis pulling the lung apart a bit, that causes pressures that affect the nerve. Is that a line of inquiry? Or?
Well, I think this is a couple of things. It is, on one hand, what you just have been discussed. The other point is, again, speaking about reflux. So when you are suffering from fibrosis, you have a change of the pressure, the intrathoracic pressure, which then opens up your lower esophagus sphincter, and then you have, again, microaspiration of acidic gastric compound, which may then induce cough. And then you have a third point. So our fibrosis in the lungs is something your lung recognizes that it doesn't belong to your body, and it's like a foreign body. So it wants to expectorate it, and that is why you have cough, because it wants to get rid of the scarring of the lungs. However, that is not possible because the scarring is in your lungs, and that is a third important point. And that is why suppressants of the nerves, these cough sensitations, is helpful in these patients, or might be helpful at least.
Right. No, thank you. Going back to the comorbidities question, we've had a question asking whether the drugs that we currently have for IPF, I guess they mean pirfenidone and nintedanib, do they in any way contribute to the development of some of the comorbidities you were talking about? I mean, is it possible?
Very good question.
Yeah.
That's
another one from Greece.
Hey, cool question. We don't have data on that. So what we do know, for instance, for nintedanib, we do know that so perhaps I have to explain how nintedanib works. So as a young physician, I did some research on so-called angiogenesis. And angiogenesis means the development of new blood vessels in your body. You can have that in a tumor, in a cancer. You can also have that in your heart after, for instance, a heart attack or when you have coronary artery disease. In some of the instances, angiogenesis, the building of new vessels, is important. In others, it's detrimental. So in cancer, the more vessels the cancer has, the better the cancer can grow. And in coronary artery disease, if you have new vessels, then perhaps the muscle heart may receive more oxygen. If you then give a drug like nintedanib, which suppresses the building of new vessels, then perhaps you're decreasing the amount of new vessels and perhaps you're decreasing oxygen uptake in the heart. This is hypothetically. So that is one of the points which was investigated, whether you have more heart attacks or more other problems associated with these kinds of coronary artery disease or similar comorbid conditions in patients with IPF treated with nintedanib. But still, we haven't seen a significant, meaningful difference there. But that is at least something you have to be aware of.
Great.
However, we see vice versa. To give another example, we have seen that at least in other fibrosis, in other organs, these fibrosis may also decrease, or perhaps we have better outcomes associated with the treatment of these antifibrotic drugs.
Great. So there's lots more to learn, I guess, here.
Yeah, a lot of more to learn.
Yeah. Another question, perhaps a final question almost. When major surgery is undertaken to treat comorbidities, do these operations themselves present a major risk to the further development of pulmonary fibrosis? What's the actual mechanism, is it? I mean, you talk about exacerbations.
So let's first speak about detrimental and then about positive outcomes of surgery. So the detrimental outcomes, for instance, surgery on the lungs. So if you're suffering from lung cancer, let's say here on your left side, and then surgery is indicated, what the anesthesiologist does is that because the surgeon has to work on your left lung, he only intubates your right lung. It uses a lot of pressure and a lot of oxygen. So he uses more pressure than he would normally, or you would normally use when you're breathing on yourself. So while the surgeon is working here, there's a lot of oxygen and a lot of pressure on your lungs, which is already affected by IPF. And that pressure then gives pressure on your fibrotic scarring, and that may induce acute exacerbation. And we have seen this, and that is one of the problems with lung cancer and IPF. We're seeing this with a very high risk that can also happen in other surgical procedures, including abdominal surgeries. That is why, if possible, we recommend having a kind of a local anesthesia. But there's also other procedures which at least might be helpful, and this is again with regards to reflux disease. It was again Ganesh Raghu who said, well, after I discussed a little bit with him, so my point was always, if you're using PPI, you're not decreasing reflux, you're only decreasing the acidic compound. And he said, well, yes, one of the points how you could stop microaspirations is that you do surgery on the stomach. That is called what we call fundoplication. And he has performed a very nice trial together with other colleagues from the US. And what they did is they performed surgery on patients who had a severe IPF and a severe reflux disease. And then they performed fundoplication, and then have seen in a very small but very nice trial that those people who had received that surgery had a better further course of IPF than those who have not received it. So in general, our surgery, especially on the lung, may have negative outcomes, but there might be at least fundoplication may have a positive outcome, but the data are still not good enough.
Great, thank you very much. A final question on prognosis. When IPF patients are told, given their diagnosis, they're often told, at least in the UK, that they've got 3 to 5 years to live. Now, we know that hopefully with antifibrotics may extend life a little bit, and we're hoping that's getting better. When a person with CHP, chronic hypersensitive pneumonitis, RA, ILD, one of the other scleroderma ILD, what's the prognosis for those? Is it similar?
This is a very good question. This is a question which is not easy to tell. So let's speak a little bit about systemic sclerosis. There's very nice data coming from Anna Maria Hoffmann-Roll from Norway. So she looked into a cohort of patients with systemic sclerosis, and what she has seen is once interstitial lung disease, once systemic sclerosis, affects the lungs in terms of ILD, whatever the initial lung function is, then outcomes are severely impacted. If you have a more or less preserved lung function, then your prognosis is much better, but the more progressed and the more impaired the lung function, the less the survival rate is. But it is much better than an IPF. For rheumatoid arthritis ILD, just to give you another example, there is some people who have the same outcome as an IPF, and there's others who have a better one. And we think that one of the very important points is those who develop progressive fibrosis, meaning they have an IPF-like subtype of rheumatoid arthritis, they have a very similar outcome. And we have seen this in very others. But currently, we don't have good data. That is one of the points, Steve, where you're involved. That is why we are currently investigating together with other colleagues, rheumatoid arthritis ILD, to understand and learn more about this.
Great. Yeah, we've got some of those colleagues are on the call tonight, I know, as well, here in the lecture. Good. Good. So finally, Michael, I think it's correct to say that nintedanib has been approved by the Federal Drug Administration in the USA and the European Medicines Agency in Europe for use for these other fibrotic ILDs that we've been talking about this evening. So there's hope. I think in Holland they're prescribing already. For the UK people here today on the call, on the lecture, the process has started. NICE is started its appraisal of nintedanib for progressive fibrotic ILD. Action for Pulmonary Fibrosis has made a significant submission to the consultation. There will be meetings this year, and we hope there will be a decision, and we hope it will be a favorable decision by September. So fingers crossed for all those people who are suffering with PF-ILD, that there may be access to antifibrotic medicines quite soon. Another question that came on the chat was about scleroderma ILD. What's the situation with that? Is that approved now, nintedanib, for scleroderma ILD?
Good question. So that would have been a bit overcomplicated to include that in the PF-ILD. So systemic sclerosis ILD, I think, was very nicely investigated also with regards to the use of nintedanib. That was the so-called census trial. And what they found there was, again, very similar to what I have shown you for the PF-ILD, a little bit less decrease there, but the relative decline, if you compare, was very similar, that you have less decline if you're suffering from SSC-related lung fibrosis once you take in nintedanib. And that was approved even before PF-ILD by FDA and EMA, and it is available in Germany for both indications. So I can treat SSC-ILD patients with nintedanib, but also PF-ILD patients. And I think the same discussion is in other countries. Some countries already can prescribe it, and at least to my knowledge, it is discussed currently also in the UK as one of the drugs which you may use once you're affected by SSC-ILD.
Yeah, it's actually
so there's a lot of things going on.
Yeah, in the UK, it's with part of the same appraisal going on now. They're looking at SS-ILD as well as the other PF-ILDs to see if they will agree to it being used. But that's great. Well, Michael, it's been a wonderful evening. I'd like to thank you very much on behalf of all of us for your excellent talk and for stimulating a great discussion. There are a number of questions that we couldn't get to, so we will ask you if you are able to give written answers to those. I mean, this is a really fantastic contribution to our webinar series, and we're really grateful. Thanks especially to all of you who asked questions, and especially to the Greek participants for their very energetic questioning tonight. Many of the questions came from Greece through translation, which is a great first. We've tended to do subtitles afterwards rather than simultaneous translation, and it's great to see that simultaneous translation has worked so well. We had, I think, over 140 people here with us tonight, which is amazing. We hope you all enjoyed the evening and you'll come to future events. Keep an eye on our website for those. Finally, I would like to thank the EU IPFF Secretariat team, Jan, Samantha, and Alba, for their hard work in putting this together tonight. These things aren't easy to launch, and they do it so well and so seamlessly that we're really, really very pleased. We recorded the session tonight. It'll be posted on our website, so if you want to, you can view it all again before you go to bed. Maybe not that quickly, possibly tomorrow. So many thanks, Michael, again. Pity you couldn't play your trumpet tonight, but maybe next time. And many thanks to everybody for coming, and good night. Thank you.
It was a great pleasure. Take care, stay safe, and look forward to hopefully to meet you all in person very soon again. Thank you very much.
Thank you, Michael. Cheers.